All right, we are after 10, so let's go ahead and get this started. I just want to thank everyone for being here. I am Emily Bleiweiss. I work in communications for University of Maryland, Baltimore. We've got a great panel of experts today who can talk about Ozempic, Wegovy, Mounjaro, and other related medications. They will each give just a couple of minute overview, kind of their expert area, and then we will open it up to questions. So we've got both Masha Yemitz and Joshua King from the Poison Center. Josh King is also with the School of Medicine as well. We've got Vashti Adams, who is with the School of Social Work. We've got Rosalina McCoy with the School of Medicine. And then we've got Charmaine Rochester Ayagalkin with the School of Pharmacy. So Charmaine, if you want to start us off and just give us an overview.
Thank you. I'm just going to share my screen and show a couple slides here in my discussion. And today, good morning, everyone. I'm Charmaine Rochester Ayagalkin. And today I wanted to describe very briefly the incretin effect before I discuss the pharmacology of the agents that we are looking at today. And in healthy individuals, when oral nutrients are ingested, it produces a much greater insulin response than when an equivalent glucose load is given in an intravenous infusion. For example, if we look at this screen, we see here in the blue box graph, that's an IV infusion given to a healthy subject, but the orange circles represent an oral glucose equivalent load. And we see here that insulin response is much greater with the oral glucose compared to that of the IV glucose. If we look to the right, we'll see in type 2 diabetes patients that this incretin effect, which we call it, is blunted and not as greatly appreciated as the healthy subjects. So when nutrients enter into the stomach and the intestines, we see after indigestion of food, these incretin hormones, which are glucagon-like peptide 1 or GLP, which we'll be talking a lot today, and glucose-dependent insulinotropic polypeptide, which is GIP, another incretin hormone. And once these hormones are released, it will stimulate insulin secretion. This happens within minutes of eating any food. The GLP levels rises very rapidly, and it has several effects and many numerous functions. First, it reduces that, it causes that insulin and glucose-dependent insulin secretion from the pancreatic beta cells. So we have insulin being secreted, and then it also causes a glucose-dependent postprandial glucagon decrease in secretion from the alpha cells. So this causes a balance in terms of the counter-regulation between insulin and glucagon. It also works on the liver to reduce glucagon, so a patient would not have that high blood sugar after a meal. It also works on the stomach to regulate the stomach emptying, and so you do not have that high blood glucose levels after a meal. In addition, it works on the brain, the hypothalamus, to promote satiety, and it reduces the appetite. So all of these effects are very, very beneficial. And so it causes low hypoglycemia rates because it works in a glucose-dependent nature, meaning if the blood glucose is high, you would have a certain amount of insulin being produced. But if it's low, there's no need for that insulin secretion. It also offers a lot of improvement in some key cardiovascular risk factors like weight and systolic blood pressure and lipids. So the glucagon-like peptide receptor agonist, which we'll be talking about today, They are also known as GLP analogs or incretin mimetics. And these drugs reduce blood sugars and energy intake by activating the same GLP receptors that is released by the gut after eating. But not all of them are created equal. As we look at this graph, we'll see, just looking at semaglutide alone, there are 3 brand names for semaglutide: Ozempic, Rybelsus, and Wegovy. And Ozempic and Rybelsus have an FDA indication to improve glycemic control in adults with type 2 diabetes, but Wegovy does not have that indication. Also, Ozempic and Wegovy has an added indication to reduce the risk of major adverse cardiovascular events like cardiovascular death or non-fatal myocardial infarction or non-fatal stroke in those adults with type 2 and established cardiovascular disease. However, Wegovy has an added indication not only for patients with type 2 diabetes and established cardiovascular disease, but it also reduces major cardiovascular events in patients who are overweight or obese. So that's an additional benefit there with Wegovy. Now, in terms of Wegovy, it also has an added indication to reduce excess body weight in overweight and obese patients and also maintain this weight long term. So in addition to those uses, so those are all approved uses, but we are seeing a lot of off-label uses or non-FDA approved uses in the community. And so it is also used in those with insulin resistance. Some patients may be diagnosed as type 1 diabetes, but they also may have some type 2 diabetes, insulin resistance. And so there are some benefits and uses in that population. In addition, patients with polycystic ovarian syndrome are also using this drug as off-label use, and it seems to be restoring menstrual cycles and helping with pregnancies. Patients with no history of type 2 diabetes are also using Ozempic for weight loss. They may want to lose 10 or 20 pounds, and so they use the drug without having to exercise in order to lose that weight. The adverse effects are all very similar among all of these GLP receptor agonists, or if they are using combination GLP-GIP receptor agonists. They are all GI side effects: nausea, vomiting, diarrhea, constipation, and abdominal pain. However, there are some rare side effects, and these are the ones that we are also very concerned and have to monitor patients carefully. Patients can develop acute kidney injury, acute pancreatitis, diabetic retinopathy, hypoglycemia, and gallbladder disease. It's contraindicated in patients who have a personal or family history of medullary thyroid cancer and in those with multiple endocrine neoplasia too. So patients must be screened for these contraindications before being placed on this therapy. Thank you.
Thanks, Charmaine. Masha, do you want to go ahead and jump in?
Absolutely. So for my kind of tidbits of information, I would like to start off with mentioning that the brand name products of semaglutide, so the ones that Charmaine just covered, are more than likely going to continue to be on shortage due to their popularity. So the semaglutide can be compounded in a licensed pharmacy using a semaglutide base, which is considered the active pharmaceutical ingredient, as long as it's being provided by a manufacturer that is registered and has a good standing with the FDA. So instead of the pen products, the pre-filled syringes, semaglutide vials can be obtained with a prescription from a licensed pharmacy. So along with these vials, people are typically instructed to use an insulin syringe to draw up a appropriate amount of the solution for the individual's intended dose. And what the poison centers have seen with these products is 10 to 20-fold dosing errors that have occurred secondary to drawing up too much of the solution. And this can occur for several different reasons. So the vials can come in various concentrations, and they usually contain multiple doses that are meant to be administered throughout the month. The dosing instructions can be very confusing, and then depending on the directions that are written, people may have to convert or calculate the amount of solution that they actually have to draw up, and the majority of these people are new to injecting or drawing up any type of medication. So this in turn causes issues with how much is supposed to be drawn up and administered. So people who inadvertently administer a larger than intended dose have reached out to poison centers for our recommendations. And that's because the main effects correlate to the main side effects that Charmaine also covered, but this can be persistent nausea, vomiting, diarrhea, and not being able to tolerate food. And these can last for a few days given how prolonged these agents are, since it's usually a once weekly dose. And many of these patients who have these persisting effects usually require visits to an emergency department for supportive management with things like anti-nausea medications, intravenous fluids for rehydration, because they can be pretty dehydrated. And then depending on how severe these symptoms are, patients may need hospitalization with this type of continued care. So this is mainly what we have seen and followed as patients progress through these types of clinical effects. Also, there is another concern that has stemmed from these products' drastic rise in popularity, and that is counterfeit or illicit semaglutide. So let me see if I can share my screen. So these are examples of some counterfeit products that are posted on the Novo Nordisk's website. And so you can see the drastic differences between the authentic Ozempic pens versus the counterfeit products. And this site does have some general guidance as far as what kind of differences to look for to make sure that you are receiving the appropriate and legitimized product. Also, there are other products that can be obtained without a prescription or seeing a provider. They can be purchased online from unregulated retailers, and they may or may not contain semaglutide or even contain other harmful ingredients such as insulin, which has been reported. And this is particularly concerning given the dangers of unknowingly injecting insulin and causing hypoglycemia and the potential for a prolonged hospital course. And there have also been products that are labeled as for research use only. And this basically just is used to bypass the regulations for medications, and has been done with a variety of substances, not just something like this. But the point to say is that these products are not approved, they're not regulated, and they are potentially untested and unsafe for people to use, but they're widely available online. Whenever I did a previous discussion on this and I had Googled, Ozempic semaglutide products, I have not stopped receiving ads on Facebook and other social media sites that these products are here and very easy to obtain. And then the last thing that I will leave off on is another issue with products that contain semaglutide salts. And this has largely been semaglutide sodium as well as semaglutide acetate. And these are essentially different compounds that are not FDA approved again. And they may have different effects and safety concerns compared to the actual semaglutide base, the active pharmaceutical ingredient. So there have been multiple issues and multiple products out there that do raise safety concerns. But outside of that, it's the issue of people who obtain these products and are trying to draw up the appropriate dose. Maybe they're not counseled as well as they should be for first-time users, and that's where the majority of poison center cases have stemmed from, is just getting a whopping dose of these meds.
Great, thank you. Rosalina, do you want to jump in?
Yes, thank you. So I think I am an endocrinologist and a health outcomes researcher. So really focus on identifying, evaluating, developing opportunities to improve health outcomes for people living with diabetes and obesity. So I'll take a little bit of a step back and talk about how this all plays out in clinic as I care for patients with diabetes, as well as in our research that looks at the effectiveness and safety of treatment options for type 2 diabetes, as well as for obesity. So we know that obesity is a major contributor to the development or worsening of many serious chronic health conditions, not just type 2 diabetes, but also high blood pressure, high cholesterol, heart disease, stroke, cancer, right, liver disease, cirrhosis, arthritis, pretty much everything you can think of. And we know that losing weight, no matter how you do it, appears to reduce the risks of these complications, whether it's achieved with weight loss surgery, medications, or just on your own. There hasn't been a comparison yet comparing weight loss surgery to medications. It's something that our team is looking at right now. But when examined individually, they're both very effective with the medications we have today. And I think the reason we're here is that, until the introduction of the GLP-1 receptor agonist class of medications, right, which is the class that Ozempic or Wegovy or Mounjaro and Zepbound all belong to, the only way many people could lose a lot of weight was through surgery. There were medications that were available and FDA approved for obesity, but none could produce meaningful enough weight loss to be really worth it. And many had serious side effects and even contraindications for people with heart disease, which is the population that needs to take these medications the most to begin with. So like Charmaine described in detail, GLP-1 receptor agonists, they activate the GLP-1 receptor, so they mimic the actions of GLP-1. So they control blood glucose levels by causing a rise in insulin levels. They slow gastric emptying, so people feel full with smaller meals and for much longer. And then they act on the brain to decrease the signal to eat. So patients don't feel hungry and they lose the urge to eat, and they stop having that reward mechanism that comes from eating. So as a result, with these kind of what we call second class of GLP-1 receptor agonists, the result is unprecedented weight loss. 81% of people who take semaglutide lost at least 10% of their body weight, something we didn't see with the other medications at all. And 41% lose at least 20%. And that's the magnitude we see with bariatric surgery. Tirzepatide, which is Mounjaro or Zepbound, is even more effective. So compared to semaglutide, which is Ozempic or Wegovy, patients who took tirzepatide for 40 weeks, they lost on average 25 pounds compared to 12 pounds for those taking semaglutide. And weight loss of at least 10% was seen in more than half, 57% of patients who were taking tirzepatide compared to just a quarter of those taking semaglutide. So, these drugs are highly effective with respect to weight loss. They also, aside from just weight loss and all the benefits of losing weight, independent of that, these medications appear to reduce the risk of heart disease, kidney disease, liver disease, and death. And we see these in people both with and without diabetes. There's a lot of research in people with diabetes, and now there's emerging evidence for people without diabetes, which is what led to the most recent FDA kind of expansion of the label for Wegovy, for example. So it's not just about weight, it's about serious complications, including death. Now, what's important is that I think our research and that of others has repeatedly shown that patients who benefit the most from taking these medications are least likely to receive them and be treated with them. So that includes people with type 2 diabetes who have cardiovascular or kidney disease, as well as people with obesity. We recently did a national study and we found that 65% or 2/3 of American adults who have diabetes and obesity, they receive medications that make them gain more weight, making the problem worse, and only 13% received medications to help them lose weight. So as we think about how we treat patients, we often make the problem worse because of accessibility issues with these drugs. And GLP-1 receptor agonists were prescribed to just 6% of US adults with diabetes and obesity. So while there's a lot of interest and a lot of need for these medications, I think the key point is that they remain profoundly underused. The other point is that obesity is a chronic disease. So when patients stop treatment, they regain a lot of the weight that they lost. So the STEP 1 trial, the extension trial, showed that within 1 year of stopping semaglutide, patients regain about 2/3 of the lost weight. So they don't regain all of their weight, but a big chunk of it. Those who lost the most weight keep the most off. And I think in part, and what I tell my patients is that reflects underlying building of good habits like healthy diet, exercise, physical activity that we know can help stave off the weight regain. Because again, not every patient will regain a lot of the weight, but unfortunately, most people who stop the medications do regain some, which makes sense because it is a chronic disease. And if we were to stop medications for the treatment of any other chronic disease, the manifestations of that disease, like high cholesterol or high blood pressure, for example, would all come back. And there's many reasons why people stop. So like Charmaine mentioned, there's common side effects like nausea, vomiting, and diarrhea. Many patients also experience a loss in quality of life because they lose all appetite and appreciation or enjoyment for food. And food is such a big part of our lives that if you stop eating, if you stop gaining pleasure from it, that can impact your quality of life. These drugs are expensive. They run over $1,000 a month without insurance, and are often hundreds of dollars a month, even with insurance coverage, because of how insurance plans are designed. And when insurance plans stop covering these drugs, there are no other options, because the other weight loss medications that health plans say are available as options, they just don't work. Like I said before, so there really is no alternative to patients. 27% of employers cover medications for weight loss. The others, right, three-quarters of employers do not. Medicare does not cover obesity treatment at all. And patients with type 2 diabetes, who could often get them for glucose control, can't afford the copays, making it out of reach. And we've shown that Medicare beneficiaries generally are much less likely to get these drugs than those with private insurance. Depending on the analysis, 10 to 15% of state Medicaid programs cover anti-obesity medications, though almost all cover bariatric surgery, which I find really interesting. So there's a lot of coverage gaps. And even when things are covered, patients are forced to stop due to drug shortages. And those are now, a nearly every week occurrence, as the demand for these drugs outstrips the supply. And that's something I am having to help my patients navigate almost every time that I'm in clinic. And as and with every effective GLP-1 receptor agonist on back order now, my patients are starting to turn to these unregulated products that Masha spoke about, that can be very dangerous and harmful, let alone not effective. So we know the discontinuation rates are high. There was a study done in a health system that looked at their patients with obesity, without diabetes. They found that at 1 year, just 1 out of 5 were still taking the obesity medications they were prescribed. Now, the rates of persistence to Wegovy or semaglutide was much higher, about 40% compared to 20% were still taking it at 1 year, which really reinforces the fact that compared to the other drugs, which are stopped much more often, semaglutide actually works, and patients continue taking drugs that work as opposed to drugs that do not work. Another study that looked at patients with private insurance found that just a third of patients who are prescribed semaglutide are still taking it 1 year. So discontinuation rates are really high, and I think we're going to need to tackle what happens as a result of this discontinuation.
Great, thank you. And our last speaker today is Vashti Adams. Vashti, do you want to go ahead? Oh, I think we're having a bit of trouble hearing you.
Any better?
That's a little bit better, yes.
Is it better without the I know my video just went off for a second. Is it better now without the headphones in?
Yes, it is.
Okay, cool. Let me just share my screen. Okay, well, I am in the School of Social Work, and I'll be talking about the social and emotional implications of these kind of drugs, especially implications regarding weight stigma. So just as a refresher, the idea of weight stigma is that body size has implications for social value. And particularly this idea that persons in larger bodies are assigned a low social value. And this lower social value is due to the assumption that persons of size are irresponsible, that they've neglected their health, that they're uncompliant with healthcare recommendations. And as a result of being assigned this low social value, we see poor physical and mental health outcomes. So things like healthcare avoidance, reductions in exercise and diet quality, various stress responses, and disordered eating. So in this kind of conversation, when we turn our attention to medications like Ozempic, Wegovy, these kind of weight loss drugs, we really want to talk about the perception of these drugs as miracle weight loss drugs and how that can relate to weight stigma. So there's two kinds of outcomes that I want to look at. The first is for persons of size that don't express interest, that don't seek out these kinds of weight loss drugs, and what are their outcomes. So we can understand that this can kind of affirm low social value because there's this justification. These persons of size are continued to be viewed as irresponsible, neglecting their health, uncompliant, again, because of this perception that if something is available, if there's a miracle weight loss drug that you could take to reduce your weight, if you're not taking it, that's affirming and justifying the weight stigma. That's affirming this idea that because you're not taking advantage, it's justified, you are in fact irresponsible. And that of course leads to that vulnerability to the poor outcomes that we associate with weight stigma. Now, alternatively, for persons of size who do express interest, who do seek out, and who do ultimately take these medications, we can see an improvement in social value, right? Because these persons become viewed as responsible, they're taking the steps to care for their health, they're compliant. These are not all ultimately positive outcomes, however, because as we've talked about, there is a risk of weight regain. So what can happen is when people have experienced this improvement in social value and improved, experiences, doctors and healthcare providers are, they have more positive experiences in healthcare because they're being seen as compliant. People are complimenting them on their weight loss and they're being seen as persons who are responsible. Once that weight regain starts, they may become more vulnerable to more extreme measures of maintaining that weight loss. So things like disordered eating, more and more restrictive behaviors. For persons of size who have already experienced disordered eating and eating disorders in the past, the effects of appetite suppression can be a trigger for a resurgence of these eating disorder behaviors. And then lastly, kind of this vulnerability to counterfeit products. People who who are more desperate to get back to that weight gain, to experience those improvements in social value, may find themselves more vulnerable to marketing, to social media, to email ads, all these things that we've talked about products that are not maybe effective and that are counterfeit, because again, this desire to improve their social value. So while these drugs certainly do have a place for some groups of patients, it's important to consider that there are implications for this social aspect of well, and in particular related to weight stigma.
Awesome. Thank you so much. So we want to go ahead and open this up to questions. So if you have got a question, go ahead and just raise your hand. We can unmute you and you can go ahead and ask. Go ahead, Mindy.
So, do we foresee a time in the future when insurance is better at covering these drugs, given all the data about how beneficial it is to people who really need it?
Rosalina, can you take that?
Yeah, no, I think that's a really important question. I think there's, there are conversations now with Medicare to see, now that we do have effective and safe drugs, should the law that bars Medicare from barring obesity medication coverage should be lifted. I think that is going to be a very important step. Right now, Medicare is prohibited from covering obesity treatments. Individual health plans, I think, are grappling with what to do because these drugs are very expensive, and yet they're also effective. I think, and the same thing for employers. I know there's been many analyses that found that, for Medicaid, for example, GLP-1s are the equivalent of the entire Medicaid budget for any given state. I think the biggest thing that will help these drugs to be covered by insurance is decreasing their price point and making them much more affordable and accessible. And I think the other is destigmatizing obesity treatment to really make it apparent and clear that it is a chronic disease and there are clear benefits to treating obesity. And the last point is demonstrating to employers and to health plans that the benefit of treating obesity is immediate. I think many say, well, if the problems happened 10, 15 years down the road, what is the advantage to a private payer, that covers a person for 3 years on average, or to an employer for paying for this. It makes sense for Medicare where people are there forever. But if people develop complications and they're privately insured, they'll end up on Medicare. So the cost is shifted. So I think demonstrating the immediate benefits, demonstrating the cost effectiveness will be important, but I think that's very hard to do given their current price point. So. Well, you're still muted.
I was just saying it's a little ironic, when you think about it. That
it is very ironic. I think given I can speak for a long time what I think about drug affordability.
Yeah.
I also think it's a little ironic that Ozempic is not one of the drugs subject to Medicare price negotiations. And the drugs that were chosen are the ones that will soon go off patent, and such price negotiations will be a moot point. So I think it will take policy solutions to make these more affordable, and thinking about the general pricing of drugs in the US.
Thank you.
So tell your legislators why we need you here. We need to advocate for affordability. We did it for insulin, so now we need to do it for this.
Do we have other questions for our experts? I know, Deborah, you had put a couple together that you thought may be something good that our experts can speak to. Do you want to unmute and ask a couple of those?
Sure. Let me just. Whoops. And also just wanted to make sure everybody has the titles, right, for all of our speakers as well.
They should have them from the media advisory, but I can drop them in the chat as well.
Great. All right. So one of the questions that I was wondering about, and we've gotten this from journalists as well, is what do we know about the long-term risks with these drugs? Or do we have to worry, some of these drugs I know a lot of people drop off of the drugs, but what if somebody is potentially taking these drugs for 3, 4, 5 years, or even a decade? Do we know, do we have to worry about monitoring for any kind of long-term complications?
So I can speak a little bit to that. So most of the trials that have studied these drugs, they were a couple of years long. Our work has looked at patients taking these medications for 5+ years, and there do not appear to be kind of new emerging concerns with regards to safety or waning effectiveness if patients are able to continue taking them. We don't yet have longer data because I think the first generation of GLP-1s were not as effective, and they had worse tolerability profiles. So really thinking about the newer medications, liraglutide, dulaglutide, semaglutide, we just don't have that evidence yet. So it's going to be very important to do post-marketing surveillance and make sure that we see what happens. I think some of the things that we need to watch for is the effects of sudden weight loss, especially if it's not done when it's done either with weight loss surgery or with medications. It can lead to other things like loss of muscle mass, osteoporosis and fractures. So I think there are risks for anything in life, but we just don't have that data yet, and it's going to be important to keep monitoring. But for now, it does not appear, based on the data that we do have, that there's kind of these emerging consequences. There are concerns, like Charmaine mentioned, about, for example, long-term, whether there are long-term effects on thyroid cancer risk, for example. That's something that our team has looked at as well. And what we're finding is that the risk is greatest in the first year of treatment, suggesting that it's an potentially a vigilance issue. You know, people are aware of this and they're more vigilant against common things in the thyroid, potentially, but it's unclear whether there truly is kind of this independent effect and when it occurs and in who and what it is. So there's a lot of research in that. But otherwise, I think it looks okay so far, but we need to keep watching.
And I had one follow-up to that as well, which folks may be wondering too, is just if you have a patient who is going on these drugs and they're experiencing, because this is what we're reading about a lot in the media, people go on these drugs, are experiencing just short-term side effects, nausea, vomiting. And it seems like there is more than one class of drug on the market, but how do doctors work with patients? Is it a dosing issue if they want to stay on these drugs and they are getting some weight loss, but they're finding them intolerable? Are there ways that they're mixing and matching certain drugs?
Yeah, so there's two things that I tell patients, and then I'll let Charmaine kind of talk with the pharmacist's perspective as well. So, you know, one is the first thing is if you really want to stay on the drug, there's a lot of dietary modifications you can do. I think decreasing the portion size, the fatty content of food, and making food less spicy goes a long way. I ask patients to keep a diary, find out what food makes them feel worse. And that works for, you know, nausea, vomiting, diarrhea, just kind of find the food that makes it worse. If that doesn't help, going to the highest tolerable dose works as well. Sometimes switching to a different medication within the same class can actually help too, especially if they're on a more potent drug. Going to a least potent can be helpful. But Charmaine, what else do you tell patients? Difficult patients in clinic I send to Charmaine, so.
Yeah, so it's the same patient pool, and we just reiterate those suggestions, and it does help. So just reducing the dosages, looking at the diet. A lot of patients eat bacon and sausage and eggs and all of that in the morning, and they take their Ozempic. They would have a lot of nausea and vomiting. So just trying to teach them how to eat in a different manner with low fat and not those high caloric diets.
Well, I tell my patients that's how they lose weight. Like this drug, by making it very hard to eat a lot of unhealthy food, that's partially, you know, how it works. So I think reframing it as kind of part of the benefit helps, and warning patients ahead of time. Like we always sit down, we go through what to expect and how to mitigate it. And I find that starting low, going slow, and knowing what to expect goes a long way. So most of my patients, kind of with careful planning, are able to tolerate them.
Anita, did you want to jump in?
Sure. I just had a question for Vasti with getting all this information and seeing in terms of people that are experiencing or going through weight loss. As we see, they see it in commercials, advertisement, and as you said, speaking to their doctor, getting, you know, the side effects. What are we seeing in the mental health as far as people that are in, like when they're reaching out for help? Are they, what are they experiencing? Are we seeing people kind of just reverting back and just saying, you know, they're giving up? You know, that type of thing, because it's a lot of pressure, you know, in terms of what they see this all the time, and they're trying to seek help, and then they're having barriers, as I'm hearing, in terms of their healthcare coverage. Just wanted to get that aspect of it as well.
Yeah, from a mental health perspective, certainly when you do experience barriers, especially, you know, there can be, as Rosalina talks about, there can be stigma around seeking support for weight loss. And when you've just faced an additional barrier around not being able to access your medications, anything around insurance, experiencing negative side effects that, you know, make it more likely to stop taking medications, all of those can also just make it, you know, more likely to stop and not to continue along the certain paths that, you know, you want to go on, especially because there can just be high, you know, personal burdens to even seeking out help in the first place, that when you experience any other external barriers, you know, it can just further contribute.
I want to check in with our reporters, see if we have any additional questions. Okay, I had a quick question actually for our folks with the Poison Center. I know we talked a little bit about like compounding pharmacies, getting the ability to make versions of these medications with shortages, but I was hoping you could speak a little bit more about that.
Absolutely. So like it was mentioned, the FDA at times will say that the specific products meet certain criteria to the point where they could be compounded. So these group of products has reached that point because of the unavailability of them. And so with all of the unregulated and unapproved products that are floating out there and widely available for consumers to go online and purchase, it's just very important to make sure that the product that a patient is receiving is what it says it is. And so if kind of some red flags whenever purchasing something like this, does it require a prescription? If it doesn't, then that's a major red flag, as well as if you don't actually see a prescriber or a provider that you can discuss these things with. And if it's coming from a pharmacy that is not listed on like a State Board of Pharmacy's website, because the pharmacies are findable, so you can search for those on each state's Board of Pharmacy website to see if they're actually active, in good standing, have a license, all that good stuff. And then for other larger compounding pharmacies that might send these vials to an actual doctor's office, there is an FDA list on their website that goes through each one that is, again, licensed and in good standing with the FDA. So it does take a few extra steps to make sure that what you're getting is safe and effective. But at this point in time, with all of the unregulated products that are available, I think for everyone's safety, those are good measures to take whenever you're receiving these products.
Wonderful, thank you. All right, last call for any questions this morning. Oh, we've got a question in the chat. We can address it here and then additionally via email. One of our reporters asks, can you speak more to the research on these drugs' effects on things like PCOS and menstrual cycles? Rosalina, I know we spoke about this a little bit in terms of pregnancy when we prepped. Is there anything you can speak to on PCOS, or would you like to have someone else follow up with a reporter?
I'm happy to follow up, I think, separately by email. I think this is an emerging area of interest. There's not a ton that is out there. And it's kind of thinking about it both from the weight loss perspective and then the insulin sensitizing perspective. Because from the weight loss perspective, both help, PCOS and improving menstrual cycle regularity. But the big question is whether the effect is going to be kind of similar to metformin, for example, which is beneficial, but does not but is weight neutral. So I think it's the mechanism would be both kind of weight loss and insulin sensitizing, which is the biggest problem with PCOS, and Charmaine put in a good study commentary as well. But I think those are the main effects. And Charmaine, do you want to jump in?
No. I was just putting this article here regarding whether these drugs have any promise in treatment of PCOS, and there was some new insight and promising therapies, but I can't say I've looked at the article. So if you do want something summarized, Lauren, let us know if you want more information.
Yeah, I think the promising thing with these drugs is that they act through many pathways, some of which we do not fully understand yet. And I think and each part of the cycle kind of feeds on itself, right? There's weight loss, there's improvements in glycemic control, independent of weight loss, but synergistic with it. The same for cardiovascular and kidney outcomes. And then we know that things that cause obesity with metabolic dysfunction cause other things, right? Which is where cancer comes in and menstrual irregularity. So I think there's so many interconnected pathways, and GLP-1 receptors are found in so many places that we don't fully know how, like which mechanism is responsible for what. And if we think about how all of this was found, right, the cardiovascular and weight benefits of these medications were a bit of a surprise during cardiovascular outcomes trials that were designed because we were concerned that they may actually be harmful, and we found this benefit. So I think we're learning a lot still about exactly how these medications work, which is why there's continue to be new discoveries about benefits as well as potential risks, and why we need to be studying them in people who are already taking therapy.
Wonderful. Well, if we have no additional questions, I think that wraps us up for our discussion this morning. I did put everyone's names with spelling and title and all of that into the chat. They should also be in the media advisory that was sent out. And if you have follow-up questions, or are you looking to connect with any of our experts beyond this, our contact information is also on the media advisory. So just let us know, and thank you so much for coming out today. And thank you to our experts. We all really appreciate it.
Thank you, Emily.
Yeah, thanks for organizing this, Emily.
Thank you, everyone.